My name is Patrick Horne. I'm a nurse practitioner at the University of Florida, and I'm also obviously part of GAP and part of this MASLD-MASH community network. So for the next 20 to 30 minutes or so, we're going to go through some things are centered around non-invasive testing or NITs. And at the end, please feel free to ask any questions that you may have. I do want to thank our sponsor, Madrigal Pharmaceuticals, for helping sponsor this program. So with that, so as I mentioned, non-invasive testing, and again, that's me. Assuming all of you that are on here have registered, but if you haven't, this is the QR code. If you still need to register for the meeting for some reason, I'll leave this up for a second if you need to take a picture of it. And then this is also a QR code link to, and we invite you to visit the GAP MASLD-MASH community network, where you can view some of the Madrigal MASH disease state education, as well as some more information around Rezdiffra's promotional program. So again, I'll leave this up here for a few seconds for you before we get into the actual presentation. Okay, so we're going to start with a case study. And this is going to be a case-based presentation tonight. So this is Albert. He's a 65-year-old Hispanic male, has a BMI of 29, comes to you or is referred to you for elevated liver enzymes. He also had an abnormal abdominal ultrasound that was remarkable for increased echogenicity, which is consistent with steatosis. So probably same with you guys, but pretty common in my practice. We're seeing a lot more referrals for sort of elevated liver enzymes, maybe abnormal ultrasounds, et cetera. Lab results, you can see here we have some. Triglycerides are 89, HDL is 41, elevated hemoglobin A1C at 7.2, so diabetic. And he's known about this elevation specifically in his ALT for probably the last 3 years. It's been sort of a mild to moderate elevation, 1 to 2 times the upper limit of normal. The referring provider did do a good job of ruling out other potential causes of liver disease, chronic liver disease, so viral hepatitis, autoimmune, other genetic reasons. So we've got all those sort of ruled out. No significant alcohol history, at least in the last few decades. Did drink some alcohol back in his 20s. Pretty typical patient with metabolic syndrome, type 2 diabetic, hypertension, hyperlipidemia. When you examine him, he's got central obesity, pretty common. But no stigmata to suggest advanced liver disease or cirrhosis. And as I already mentioned, his BMI is 29. So with all of this, knowing that other things have been ruled out, the most logical diagnosis is going to be MASLD, or metabolic dysfunction associated steatotic liver disease, right? So we're going to go through this process. So now that we sort of have a diagnosis of MASLD, we need to figure out where he is at in terms of fibrosis. Does he have cirrhosis? Does he not? And that's what tonight's talk is going to be about, is about non-invasive assessment, non-invasive tests, NITs. So this is sort of what our landscape looks like in 2025. So we've got imaging biomarkers for both liver fat as well as for liver stiffness. I'm sure you guys are probably familiar with some of these. Just starting with the liver fat sort of assessment, the most common ones we see are CAP, which we typically see from FibroScan. And then you've also got MRI-PDFF. And then if you look under liver stiffness biomarkers, same thing. So VCTE, which is measured in kilopascals, that goes along with your transit elastography, most commonly FibroScan, which we're going to touch on here in a minute, as well as MR elastography. And there are others as well, as you can see listed. Pretty commonly used, mainly because of their convenience and their ease. We do have some clinical or laboratory predictors we can use, FIB4 being the most common. And again, we're going to dive into that a little bit deeper if you're not familiar with FIB4. There is a NAFLD, because it was created back before the nomenclature change, but NAFLD fibrosis score, and there's also APRI that's been out there as well. And then there's some proprietary markers. So ProC3 is kind of a newer one. ELF, which we're also going to go through tonight, is also an up-and-coming and more commonly used one. And then there's some others like FibroSpect and Fibrometer. We're not going to touch on those tonight just for the sake of time. And then you've got some combined rules as well. FAST, MAST are ones that you will commonly see as well. We're not going to have time to go through those either tonight, but they just be aware they are out there. So let's start with Fib4. As I mentioned, that's sort of the easiest, most straightforward one. And you can see why if you haven't used it before, but you can see why it's so easily used. So it's very simple: age, AST, ALT, platelet count. And it's actually very, very good. It has a very high negative predictive value, or a high predictive value of whether or not someone has advanced liver disease. So your cutoffs are 1.3 and 2.67. So if you do a Fib4 in a patient and they have a Fib4 score of less than 1.3, they have a very high negative predictive value of having advanced fibrosis. On the other side of the coin, if you do a Fib4 and you've got a score above, say, 2.67, that has a very high indication that they most likely have advanced fibrosis or could have advanced fibrosis, and then probably need a secondary assessment, a secondary test. So this is sort of what the guidelines recommend as your number one sort of starting point, go to, because again, you always have an age, and 9 out of 10 times you're gonna have your liver enzymes and you're gonna have a platelet count. So it's a great place to start. One of the proprietary tests that I mentioned earlier, ELF, which is the Enhanced Liver Fibrosis Score, is a newer kid on the block, but is up and coming and definitely is out there, and it is commercially available. It has some benefit as well. So if you take a cutoff point of 9 as a score, and you can see that it ranges from 7 to 15, you use a cutoff of 9, it's got a specificity of 60% and a sensitivity up to 85% of assessing for the presence of advanced fibrosis. So it's a good test. Like I said, it is a commercially available test. It is a send out test, but that can also be something you can use in addition to or in place of the Fib4 if you want to. So now we're going to shift a little bit to some of our diagnostic or our imaging studies. So mainly we're going to talk about VCTE, or transient elastography, aka FibroScan. Then we're going to talk about MR elastography. But in general, these tests measure liver stiffness. And so just a general definition of stiffness, it's the ability of an object to resist deformation in response to an applied force. So in this case, where we're doing either ultrasound guided or MR guided, we're using a shear wave. And what that's doing is it's measuring the stiffness. The shear wave will travel faster through a stiffer liver. So the more liver stiffness, the faster the shear wave. So again, that would mean that liver stiffness increases as you have more and more fibrosis. So we'll touch on vibration-controlled transient elastography, VCTE, again, most commonly known as FibroScan. It's non-invasive. You get 2 pieces of information with this, as I mentioned earlier. You get the liver stiffness, but you also get the cap. And a lot of times this can be done as point of care and takes 10 minutes or sometimes even less, depending on the situation. So the liver stiffness, again, it correlates with the extent of fibrosis. And then the cap actually correlates with the degree of liver steatosis. So you're getting, again, 2 pieces of information with this machine with one test. You're getting liver stiffness, and you're also getting the cap or degree of hepatic steatosis that's present. And then both of these can be used as biomarkers to assess the severity of MASH, which is important when you're trying to determine whether someone has advanced fibrosis or not. Just some considerations to take into consideration, I guess I should say. If you're doing VCTE, I don't know if you guys have this in your practice or are familiar with it or are trained on this. I'm actually trained on it, so I have a little bit of experience with it. The important things to remember is you need to have 10 valid measurements. You have to have at least 10, I should say. If you have less than 10, it's not a valid study. So you need to have at least 10 valid measurements. Your IQR needs to be greater than 12%. Your IQR/MED needs to be greater than or equal to 0.3 if you get a liver stiffness measurement greater than or equal to 7.1. You always want to look at the image quality. So this is an example here of the pictures you're going to see, and when you do your 10 measurements, you'll get 10 individual pictures all on the screen together. And what you want to make sure of is that they are all as uniform as they can be. There may be some variation, but in general, you want them to be as uniform as they can be, knowing that That just reassures you you're getting adequate imaging. You want to make sure or assess what is your success rate to get those 10 measurements. Because if you had to do it 60 times to only get 10, that's not really going to be a valid test. You know, if you need 11 shots or 12 shots to get 10, then yes, that's a valid test. And you want your shear waves to be very clean and parallel, just like this picture is showing. So if you're not seeing them sort of parallel like that and clean, those images are probably not ideal, and you want to sort of reevaluate and reposition. And that's where the experienced operator comes in. You want somebody who's doing these a lot, doing these on a daily basis. You have to do, you know, X amount to be certified. But the more, it's like anything, just like any ultrasound or anything you do, the more you do, the better you're at. So you want to make sure whoever's operating this machine knows how to do it and has done a lot of it. Some other things to take into consideration that can not only limit the use of it, but can skew your results. So if you have a very active hepatitis, so you've got high transaminases over 100, or a patient with cholestatic liver disease, whether it's acute cholestasis or chronic cholestasis, that's going to skew your numbers. It's going to make the liver appear likely more stiff than it may or may not be. So you got to remember that if you have that information in front of you and available before you do the FibroScan, take that into account. Other factors, it's important that patients come in fasting, minimum of 2 hours, ideally more like 3 or 4 hours before the test is done. If they've just eaten a large meal, especially if it's a very large, heavy meal, that can also skew your results artificially high. So fasting is important. Alcohol use, again, if they've been drinking a lot of alcohol and there's a lot of inflammation in the liver, you've got elevated transaminases, that may skew your results. Body size, obesity, a BMI greater than 35. Even though there is an XL probe to help overcome some of that, high BMI is going to potentially throw off your results. The presence of ascites, it's not recommended you do a FibroScan in the setting of ascites if you know they have it, because again, now you're talking about fluid there. It's going to change your whole numbers. Liver mass, the same thing, especially if they have, say, a large liver mass. And if you potentially do your FibroScan over that liver mass, you're not actually assessing liver stiffness. You're sort of assessing the mass. So if you know that information, would probably, in my mind, recommend you avoid doing a FibroScan in those settings, because I don't think your results are going to be accurate. So we'll switch over to MR elastography. Not available everywhere. I work at an academic institution, so I do have access to it. It can be helpful. It gives you nice, pretty pictures. You can see sort of over there on the far right-hand side, top of the 4 pictures. It is shear wave technology, just like you have with VCTE, just not through ultrasound, but through MR. And it produces those multicolor elastograms, as I mentioned over there to the right side. Again, has some limitations, or at least things you need to consider. BMI is a limiting factor. Is their BMI so large they can't get in the MRI machine? Iron overload, that can also skew your results. Not everybody, of course, is a candidate for an MRI. Maybe they have claustrophobia, but maybe they also have implants. Maybe they have some sort of metal in their body. Maybe they have a non-compatible pacemaker, et cetera. So all those things you have to take into account, of course. Congestion in the liver from, say, heart disease, that's going to throw your results off potentially as well. And then it is an MRI. It is expensive, obviously way more expensive than an ultrasound-based assessment. So insurance is going to play into that decision as well. So this is the chart. It's not meant to sort of compare and contrast at saying that one is better than the other. What I do like about it, it's mainly just to sort of summarize the 4 that we've just gone over briefly. It gives you their measurement. It gives you, the measurements, the components in the measurement, the formulas for the FIB4 and for the ELF. It gives you your cut points, both rule in and rule out cut points for advanced fibrosis versus mild fibrosis. It gives you a little bit about the limitations that we talked about, as well as the strengths. So it's a great slide just to have access to, as a quick reference. But again, we're not comparing FIB4 to VCTE or ELF to MRE, et cetera. So we're going to jump back here to our case study. This is the exact same slide we started with. Nothing's changed here. Just to give you, I'll give you a few minutes to sort of just refresh if you'd like. Okay. So again, we made the diagnosis of MASLD. All right, so now we got a few more labs on him. So we've got it. We've got our liver enzymes. We got our ALT. We got our AST. We have our platelet count. So we know his age. We know he's 65. So first step, let's do a Fib4. All right, so Fib4 is 2.22. Well, what does that mean? We talked about earlier, less than 1.3, high negative predictor value for advanced fibrosis, greater than 2.67, very high value, suggesting the high possibility of advanced fibrosis. Well, he's in between. So this is from the AGA. This is sort of their guidance for non-GI, non-hepatologists, so primary care, endocrinologists, et cetera. So we know that he meets the criteria for cardiometabolic syndrome for MASLD. He's got 2 or more metabolic risk factors. He also has type 2 diabetes, and he had steatosis on the prior imaging study. So then you dig into the history. So no excessive alcohol intake for Albert. We got the CBC, we've got the liver enzymes. So we do our Fib4, and you can see he's in the indeterminate area. And with the Fib4, one of the limiting factors with it is there is a very large range of indeterminate. So when you get an indeterminate, we got to go a little bit further. And this sort of jumped ahead a little bit to what our next step is. So he's indeterminate. What do we do next? Well, if you follow the algorithm, in this case, we decided to go with liver stiffness measurement. In this case, we did a FibroScan. So his FibroScan was 6.7 kilopascals or kPa. And so again, if you look back at the chart, that's in the blue box, which is low risk. So at this point, we're recommending lifestyle modification. We're recommending management of the metabolic disease. So we got to get his diabetes under better control, or somebody does. We got to, make sure his cholesterol is under control, make sure his blood pressure is under control. And then we got to work on weight loss. But because his FibroScan is on the lower side, we really don't need to reassess for a couple of years on this. Give him time to sort of do those lifestyle modifications, and then we can reassess in maybe 2 to 3 years, unless something changes clinically that makes us concerned that he's progressed or he is progressing. But for him right now, with that FibroScan score, he's low risk. He's got time to work on these things, and then we can reassess in a couple of years. And that wraps up my presentation. So we certainly have time for questions. If you guys have any, I'd be happy to answer anything I can. I'll open it up.